And we're back. We have two guests again from Australia, Julie Ayre and Hazel Jenkins. Thank you all both for coming on. Let's start with Julie. Julie, can you give an intro and background on yourself? And then Hazel, you can take it from there.
Thanks, Chris. I'm really excited to be on the podcast today. I'm a postdoctoral researcher within the Sydney Health Literacy Lab, and that sits within the School of Public Health at the University of Sydney.
How about yourself, Hazel?
Thanks, Chris. So my name is Hazel Jenkins. I am a senior lecturer at Macquarie University. I'm a chiropractor by background, and most of my research has been focusing around back pain and particularly the implementation of research into clinical practice.
And I initially reached out to Julie because she was the lead author on a paper and one of the topics we're going to discuss today on a decision aid for sciatica, should someone have surgery and what are their options. And then Julie was nice enough to loop Hazel in and provide more of the clinical component and have kind of a shared discussion. So we're going to dive into the paper, but also more broadly, what are decision aids, why are they important, and then also what is shared decision making and how can this all influence and improve a clinical encounter with patients. Let's start with the big topic. What is shared decision making? And Julie, I'll have you start here.
Yeah, thanks. So shared decision making is all about the patients and the clinicians working together to make a health decision that takes into account both the medical evidence about a health issue and a health decision, but also the patient's personal values and preferences. So you might not need to use shared decision making every single time, or the patient in fact may not want to engage in shared decision making every time, but it is a really fundamental part of person-centered care, particularly when the evidence doesn't recommend one particular treatment over another. It's important because it improves rapport. So it's really giving an opportunity to improve that relationship between the clinician and the patient. We know that people often want to be more involved in their care than they're actually given opportunity to. And obviously the goal there is also around making an informed decision and one that aligns with your personal values and preferences.
I feel like this term has been used a lot recently. Why is it now, or maybe it's just because I'm unfamiliar, but why is it now so common in research and that term and it being utilized? And what is kind of the history of shared decision making?
Yeah, so I guess if we think about clinical communication more broadly, traditionally it started from a very paternalistic place. So the idea was kind of the doctor's in a place of authority or the clinician is in a place of authority. They know what the best treatment option is for any given patient. But as we've kind of progressed and moved in towards this idea of person-centered care and seeing a more holistic view of the person and taking into account what's important to them, we can't actually make those decisions without the patient. So that's where that comes from. Hazel and I were also talking the other day, and I think, we have a much more critical eye on the evidence base these days as well. And there's a lot more areas where we see kind of equivalence between different treatment options, or we can see the gaps in the evidence a bit more clearly than we probably used to. And so it's a good opportunity there to kind of really think about what the limits of the evidence are and what that means for high quality care. If we look at medical education, we're seeing more and more of these shared decision making skills embedded in that education. But when it comes to practice, I think it's quite interesting that I think there's a lot of patients who would be interested in learning more about a health issue, learning more about a treatment option, but it's still quite unusual for a patient to kind of say, can you tell me more about what my different treatment options are? What happens if I wait and see, or if I do nothing, and what are the benefits and harms of that treatment option? So we've still got a long way to go if we're thinking of kind of an endpoint where patients are really interested in learning about their different treatment options as well.
And I know your research is also involved with health literacy, and I think those concepts are probably intertwined, but can you touch on what health literacy is and how a better sense of health literacy and understanding how patients can advocate for themselves can also influence this shared decision-making process?
Absolutely. So in terms of a definition of health literacy, we can think about that as the skills we need to be able to access, understand, appraise, and use health information and services. So, of course, it's going to be really important for shared decision making because it's so closely tied to being informed about the nature of a condition and the different treatment options. It's really related to question asking as well. So we know that being able to ask questions is a really important skill when you go and see a clinician, but it's going to be harder to do that if you're struggling with kind of the information that you're being given in the first place. The other thing that is really important to stress with health literacy is that we can't just think about it in terms of personal skills. That's just kind of one part of it. We actually need to think about the health systems and the health services as well, because the way that we deliver health communication, whether that's written information or verbally speaking to a patient, can make a huge difference to the amount of information that they can take in and what key messages they're able to understand as well. So in terms of health literacy, we have a lot of strategies that we can use to help people take in that information.
Let's go to Hazel. So from a clinical perspective and clinician perspective, how can providers actually implement this shared decision-making in day-to-day practice?
Yeah, it's a good question, and one that can be challenging to start with until you get it into a bit of a clinical flow and actually just sort of get it slotted in there so you're using it more routinely. So shared decision making, it sits within that spectrum. So different levels will be more or less appropriate for different people. But what's really important is that the patient knows that there's a decision to be made and that they can have some input into that. And that's often what they don't realise. So it's important to establish early on within the consult when you first see them that there will be a decision related to the different management options that that might be appropriate for them, and to help try and determine how involved the patient actually wants to be within that decision-making process. So some people may not want much involvement. They may be very happy to just go with the recommendations of the clinician because, they have the expertise in that field. But others may want to be involved but not actually realise that it's an option at the start. So it's important to give that, to let them know that that is an option. Potentially being involved can help give them some ownership over the decision, help give them a sense of control, which is really important to some people as part of that recovery process. So it's good to sort of start that process even before you've done, really started your history, etc., in your clinical consult with a little bit of an explanation of what's going to happen. So something like, I would like to find out more about why you're presenting here today. I'll ask you some questions, perform an examination to help determine which management options might be of most benefit to you. I'll then explain my findings and the benefits and risks of the different options, so you can consider what you'd like to do next. So just making sure they're aware that it is up to them. Can then follow that up with, you can decide whether you would like to follow my recommendations, discuss the options further, or seek a second opinion or more information. So just really letting people know that there is that choice to be made. The next sort of step towards implementation is making sure that they've actually got enough information to make those decisions and feel like they have enough. So, people are very likely just going to go with the clinician recommendations if they don't feel like they've been given enough information anyway to actually, sort of add to that decision. So some of the things that are important to either find out about or tell them about, firstly is during the history and when you're talking to them, ask them about what they want out of this treatment or out of the management process. What are their goals? That can really impact the different management decisions and whether they decide to take them up or not. Then really importantly, you need to provide them, when you're telling them about the management options, you need to provide them about the different potential benefits and potential harms of the different options, including the option of doing nothing as well. I think it's probably one of the hardest for clinicians to get their head around. And then make sure that they've understood the information provided, ask them if they have any questions, and then, that's often when, if someone wants more involvement in that process, then those questions will open up to that more shared decision-making part of the journey.
What are some of the reasons why clinicians aren't commonly utilizing those steps that you mentioned during the clinical encounter and during the evaluation. There's a variety, I'm assuming, and Julie, you kind of mentioned part of it is like this just wasn't originally the foundation of medicine. Hazel, do you have any practical ideas of whether it was during the schooling process or just the sheer amount of different types of presentations that come in? Does it just feel overwhelming to try to go through this with every patient, and the clinician doesn't have the information readily available? What are some of the reasons why this may not be commonly implemented?
Yeah, and look, there's quite a few reasons which might impact it. So one of them, as you mentioned, is training. So particularly if you graduated a longer time ago when this wasn't something that was as regularly talked about or utilised, you may have just had no training in how to deliver or how to talk to someone with this in mind. So that can be very challenging, and you're used to practising a certain way, and so to actually change that style of practice, it can be very difficult. And so that's where things like the decision aid that we're going to be talking to can be quite helpful to actually provide tools, not just for the patient, but also for the clinician to help this process. One of the other big barriers, I'd say, is that there's a feeling that it can take more time within the consult. You know, if you have to start discussing something with a patient, that's going to take longer than if you just go, this is what you should do. And so that's a very big barrier for a lot of clinicians, that time component. And it takes practice to be able to do it effectively within a good patient flow and within the time constraints that you have. And often that practice is what we don't have the opportunity for in clinical practice, because you've got this full book and you've got patients back to back, and so it's hard to start putting that in there. So again, that's when I think these tools can be really useful to be able to at least start the process. So as we'll get to, the decision aid, lets the patient know that there's a decision and there's questions. So at the very least, if the clinician gives them that decision aid, at least they're getting some of that, even if they don't feel they have time to get more into the practice. And then I think there is, that we often have our own unconscious biases, and where we genuinely believe, for whatever reason, that a particular treatment is the best and that is what the patient should have. And so, there's that barrier of potentially not providing the entire evidence base to the patient because of your own beliefs as well, and that you really think that's what's best for them. And that can be very challenging to change, because that's the clinician's beliefs as well. And then finally, I think it's just that they might be concerned that patients don't know enough to make an informed decision. But I'd say that's our role to actually give them that information to allow them to do that.
Before we move on, Hazel, I'm curious your thoughts as a clinician for the options that maybe you're biased against providing because you either strongly disagree with the evidence, or not with the evidence, with the application or implementation of it, and or the evidence just isn't there, but you're trying to outline all of the possible interventions that they could receive. How many options do you provide? So for example, I know you've done research in education on low back pain. There's so many different routes they could go. What lanes and how do you know how much to provide versus, well, these are all the other options that really don't have support, but a large majority or a large portion of individuals do seek out that care? How do clinicians know what information to provide?
Yeah, that's a really good question, because there are so many potential options out there. I would tend to think of it in terms of I guess classify the options in terms of how much cost, time commitment, or potential risks there might be involved with them. So I sort of have a bucket for your more surgical options, because they'll have certain concerns related for those. Then you'll have your more what I'd call conservative treatments, but particularly coming from a chiropractic background, you sort of manual therapy options, and then maybe you sort of more medication options, and then you're doing nothing. And so there'll be, and depending on the condition, obviously, there'll be more or less of those different options. But we generally find that a lot of the evidence in those sorts of areas can be quite similar to each other, or, so you can have that sort of discussion more globally. And then that's often the big decision that needs to be made. Do we need to refer you to a surgeon to follow more of a surgical potential option, or are we going to look at you conservatively first in our practice And then once they've made that bigger decision, then you can start to get down to a little bit more of, okay, these are the specific conservative options that we have. This is sort of what I recommend there. But so it's, trying to keep it the big picture at start and then moving down.
Julie, let's dive into decision aids. What are they and why are they helpful?
Yeah, so decision aids are tools that give balanced and evidence-based information, and they guide the patient to think through which benefits and harms of the treatment options are most important to them. So it's all about integrating their personal values with what they've learnt about the treatment options. So it's kind of, a template for shared decision making, as Hazel said, that guides people through that process. There's really strong evidence behind them. So systematic reviews of more than 100 trials have shown that patient decision aids increase knowledge about treatment options, they increase people's accuracy of risk perception, and they increase alignment between informed values and the health decisions that people are making as well. The other thing that's worth mentioning is that there's actually quite specific checklists for designing patient decision aids that in terms of what has to go into each of those steps. So it's including things like making sure it talks about what the condition is, what the natural history is, describing the different options, and often including a wait and see option as a part of that, and then the benefits and harms and reflection on personal values. So when you create a decision aid, if you're using those checklists, you kind of know that you're hitting all the marks for a good informed decision making. Yeah.
I've seen, I think, 3 ones now out of Australia. The sciatica one on shoulder, rotator cuff related shoulder pain, surgery or non-operative management, and then ACL. Is there more decision aids, or is this more commonly utilized in other areas of medicine or healthcare? It seems like, at least in the rehabilitation field, it doesn't feel like there's a broad amount of decision aids so far.
That's a good question. It does really vary. So there's quite a lot that's on cancer treatment options and cancer screening as well. And there are some really interesting patient decision aids for older adults too, where they're also trying to balance different conditions and different treatment options that have different impacts. But honestly, it's across a really wide range of different conditions. There's also a lot for diabetes and cardiovascular disease. So there's no, I wouldn't say it's specific to a particular area of health. Yeah.
Let's dive into the one y'all published, the sciatica decision aid. Julie, we'll stick with you. Can you touch on what it is and how you went through that process of creating it? Yeah,
so the decision aid that we created is for people who have sciatica and they have a referral to see a spinal surgeon. So as Hazel kind of mentioned, we're just focusing on that big decision between having surgery or going with other treatment options. We're also looking, and Hazel might want to speak more to this, but looking at people whose sciatica is most likely caused by lumbar disc herniation with pain that's less than 6 months. And it's not designed for patients who really need that surgery quickly. So patients with quad equina and things like that. So it's really these people who are in a grey area where they've got quite a lot of pain. It hasn't recovered within a couple of weeks. And so they've got this referral to see a spinal surgeon. We did a lot of work with people with lived experience before we designed the decision aid. And part of that discussion was around just how overwhelming it is to go and speak with a surgeon. You have a really limited amount of time. There's a lot of medical jargon that gets thrown at you. And then obviously there's a big power differential as well, because it's like really intimidating to be talking to a surgeon or asking questions, pushing back, that kind of thing. So the decision aid was really designed to help people prepare for that appointment with a surgeon. So yeah, in terms of how we developed it, we looked at the literature to make sure that we were up to date with the latest evidence base, including there's a number of systematic reviews that have been published on the effects of having surgery for sciatica. And they've really found that there's one main study that kind of informs that decision-making process. So, those results showed that you might have faster recovery with surgery, but by 12 months, the outcomes for leg pain are kind of similar in both the conservative management and the surgery groups. But on top of that, it's only one study, so it's got that real sense of uncertainty about which way forward. Anyway, so with the decision aid, we present that evidence, we show those statistics and help people understand what that evidence says. We talk about the benefits and harms of each of those options. And then we use quite a lot of strategies to help people. I guess one of the key messages in the decision aid, and when we were doing the user testing, I think people found this quite interesting, is that we have to do a bit of work to help people understand that their values are important and that their values make a difference to the decision that's being made. And so we did that in a number of different ways. So we gave examples of different values that people could have. We talked about personal stories where people would describe how they came to that decision. So they're not focused on whether the surgery worked well for them or not. They're focused on, these things were important in my life, and that's how I came to this decision of whether to have surgery or try other options first. And then towards the end of the decision aid, the patients can also use our interactive values clarification tool, which is a fancy term, but basically that just means that we have some rating scales where people can see how their values weight towards those different treatment options. It's not very didactic, so it's not going to say, you've said all of these values and they align with surgery, therefore you should get surgery. It's much more gentle and kind of like, these are some of the reasons you've given, or some of the values that you've given that kind of align with the surgical option. There may be other reasons that we haven't captured here. Have a think about how this fits with how you're feeling in a more general sense. So that's kind of that's what's in the decision aid and the general process that we went through, and we followed. Once we had that prototype, we followed it up with some user testing with patients and with clinicians to make sure that it was easy to understand and hopefully as practical as possible as well.
Hazel, do you want to dive into, during the clinical encounter, how do we actually implement this decision aid during kind of a real world scenario?
Yeah. And that was one of the things we found quite early on, is that we'd actually have to have a few different strategies for how it could be used in practice. So when we first started this process, we were thinking of it being something that would be used by the surgeon, because the surgeon's the person who's making that final diagnosis. So usually at the level of the general medical practitioner, they're identifying someone who might have sciatica and might have surgery as an option and referring for the surgical consult. But it's the surgeon who makes that final diagnosis, who usually has the imaging. At least that's how it is in Australia. So we were really seeing it as something that then the surgeon would potentially bring out in the consult and go through with the patient and discuss at that time point. But from some of our feedback from both the patients with lived experience and also from the surgeons themselves, we realised that we were going to have multiple strategies around the implementation, because it was very likely the surgeons just wouldn't find the time to use it that way. And also, really importantly, that the patients would probably be getting that a little bit late in the process, because they were describing that they feel almost a bit, almost intimidated in the surgical consults, that they don't feel like they have the right to ask questions. It's quite a short time frame in there, and they know that the surgeon's really busy, so they don't want to take up their time, and they feel potentially a bit pressured to make the decision on the spot. And so what we wanted to do was give people more information before they get to the surgical consult, so they already had some idea about what the decision to make could potentially be. And then also that they had the right to ask questions, and that they didn't have to make the decision right there on the spot. They could go home and think about it as well. So the decision aid ideally is given to the patients before they see the surgeon. So that could be from the clinician who refers them, which would actually be a really nice time to give that to them. So basically, we're referring you for the potential of a surgical opinion. This is something you might have. The surgeon will finalise that diagnosis, but here's some information to have a look at, so that if it does turn out that you do have that diagnosis, you've got some information about what the different options are before heading into the surgical consult. If they don't get it there, then it's something that potentially the the surgeon's office could send out to them when they know they've got an appointment coming out. So they've got that information beforehand. So then the patient can read through that, just have a bit of an understanding about what sciatica is, what the different treatment options are. And then we've got this really nice section for the patients that discusses what they can think about during the consult as well. And so it's got there some examples of some questions that they might want to ask, or at least that they've got the ability to ask questions. And it's got some work that's tailored for the surgeons to be able to go through during the consult to just help explain that decision in quite a quick and effective way. And then lastly, we've got a third section in the booklet, which is really for after the consult. So at that point, they now know, yes, I've definitely got this diagnosis of sciatica. I know that surgery now is definitely a treatment option, or conservative care or wait and see as a treatment option. And so then we've got things like the personal stories that Julie mentioned. We've got the interactive decision tool, which is this lovely online tool where they can play around with their values and what they mean and see how that would potentially impact their decision. And they can have a look at that after the consult and be aware that they don't have to make the decision immediately. They can go away and think about it, and then potentially ring up the surgical office to let them know their decision, etc.
And I'll just jump in quickly as well. One of the nice things about the that tool that helps visualize their values, we got some feedback from clinicians who also said that they liked being able to visually to see that visualization, and they felt like that would help with those shared decision-making discussions to really help integrate the personal values into the medical evidence as well.
During the visit to the surgeon, and this can probably extend beyond just this sciatica decision aid, but what are questions that patients should ask their surgeon?
Yeah,
Hazel, if you want to start. Yeah.
Sorry. So the very basic ones to start with are just, what are the potential benefits of this different treatment option, and also the other options, and then what are the potential risks or harms that might have. These are all things that we should go through as a clinician. It's part of a consent process. But sometimes we go through them quite quickly. We know them really well, so we might run through them quite quickly. We might not say them in a way that the patients understand. So just having those questions there that, even if they've got a little bit of that information, if they haven't quite fully understood it, that they have that right to ask more questions around that. Also probably around, getting a second opinion, or just, asking if there are other options other than the ones that have been described, or if there are options for a second opinion as well. I think probably those are some of the key ones. And then the last one is also just around recovery. What's it going to look like after I have that particular treatment option, particularly in reference to surgery. But
yeah, it's unfortunate that, at least in the States and the patients I've interacted with, even though they're considering elective surgeries, if the surgeon that they're consulting with is saying they need it, even though they potentially don't, there's that inherent hierarchical kind of assumption and belief that they have to follow what the surgeon says, and trying to navigate that as the rehab provider and not completely contradict, but also provide a devil's advocate of, well, I think it's warranted to receive a second opinion. These are some other options. How comfortable do you feel about what your surgeon explained to you? Do you have any more questions about the surgery, or what, if you didn't get the surgery, what that would look like? And these decision aids just provide that, maybe the more confidence or autonomy for the patient to feel like they have an option or options, and that they should or could ask these questions, as opposed to, like y'all mentioned, just kind of following through blindly with a recommendation, or feeling almost forced into a surgery. Was there anything that y'all realized with the decision aid that you learned from that you didn't realize was going to be the case when you went about this, either talking with patients or or you already mentioned some of the logistical issues with kind of the logistics of being with surgeons and that time and how there are other ways to implement it. But is there anything else with this specific sciatica decision aid that y'all learned from and weren't expecting?
I think I was pleasantly surprised that we actually had some feedback from the clinicians as well that they would potentially give the decision aid to patients who weren't necessarily considering surgery, but just to show them what that outcome with non-surgical management can look like as well. And quite a few patients found it quite reassuring, that you can have the same outcome by 12 months. So I think there's potentially some broader use that might happen with the information that's in the decision aid, even if it's not strictly being used as that kind of decision aid. And I think we just got so much positive feedback on that interactive tool that shows the values, both from the patients and the clinicians. And I think that really speaks to, people that are interested in those kinds of discussions, both from the clinician and the patient perspective. And it's just about having the skills and the resources there to help facilitate those discussions. Yeah. Hazel, was there anything you wanted to add?
Yeah, look, I think I just echo that there was a lot of positivity from the people we consulted about the decision aid, for the most part. So most of the clinicians, etc., were really happy to have a resource like this that does just help to make their job a little bit easier. There was a little bit of a sense from a couple of the surgeons, maybe in particular, that getting the decision aid beforehand may not be that useful for people because they haven't had that final diagnosis yet. So they're sort of, we're the ones that make the diagnosis and should be providing those options. There was a little bit of a feeling around that from a couple of the surgeons initially, but I felt that in our discussions that also changed for them a bit. They sort of understood a little bit more what we meant with it, that it's not that we're providing that diagnosis early on before it's been sort of made, that we're just providing them with information so that when the diagnosis is made, they've got more options at that point. So I think even if there was a little bit of resistance from some initially, they soon saw the benefit of it.
And we made adjustments to the patient decision aid to make that clearer as well. So it's kind of more signposted. I think it's now more clearly signposted around the specific discussions that the patient has had with the surgeon.
For that, pretty much that one study that is included in this decision aid, or is that the prime component and what you all outline, as you mentioned, by the 12-month mark, surgical versus non-surgical outcomes are relatively similar. If a patient asks, why is that the case? How do you navigate that, Hazel, if you have kind of practical experience for that? And then two, just with the study itself, was that from an outcomes of pain? There's that kind of quick improvement after the microdiscectomy or after the surgery. Was that quick improvement related to just a reduction in pain, or the other potential radicular or radiculopathic like symptoms they're experiencing?
Okay. Look, it's always challenging to address questions like that, like why are things similar by the time you get to 12 months, especially when it's a big thing like surgery, because people expect surgery to work and to make you better. It's definitely tricky to navigate. So what the study did show was that the people who got surgery did get quicker outcomes. And that's sort of what we would kind of expect from a surgical approach. You're potentially taking the pressure directly off the nerve using that surgical approach. And so that you would hope would give you quicker outcomes. But then when you're looking at the long term and that people are about the same at 12 months, I think that's just reflecting that the body does heal itself. And so over that longer period of time, yes, it takes longer because we haven't directly taken the pressure off immediately, but the body does get back it goes through that healing process. And then as people get back into their normal activities, etc., they can end up at the same place. So one of the things we were talking about in the decision aid is that part of your own values could be just around, is it really important for you to get a lot of pain relief right now? Or is it not so important and something that you can wait for because you'll probably get there in the long term? And that becomes part of that decision.
Did that study, Hazel, do you know if, because sciatica, it's kind of an umbrella term for, could be reticular pain, could be more radiculopathy with motor symptoms. Was that microdiscectomy just reducing their pain, or if there was a decrease in motor strength or in sensation, that those were also improving, or is it just pain that they were looking at?
I'm fairly certain the primary outcome was pain, Julie, but correct me if I'm wrong here.
Yeah.
So they were looking at leg pain specifically.
Yeah.
So if the patient had specific neurological symptoms, so particularly weakness, and especially reflex loss, and especially if that was over multi levels, then they wouldn't have been indicated for that particular study. So those are the sort of groups of people that probably do need surgery quickly, and so this decision aid isn't for those people who are really showing those really hard and progressive neurological signs. This is more for that group that's more the leg pain is the predominant symptom, maybe some more mild neurological symptoms, absolutely, but predominantly for leg pain.
Is there anything else with this topic of decision aids or shared decision making that you all feel like you wanted to bring up and that I haven't discussed or asked about yet?
I think for me, it's just not to underestimate the patient. I work in the Sydney Health Literacy Lab. I'm obviously very passionate about health literacy, and I think it's really important to think about what we can do to meet patients' needs in terms of communication, and that's kind of the first step to being able to engage in that shared decision-making process.
How about yourself, Hazel? Any other thoughts before we wrap it up?
I think probably just in terms of implementation, just trying to even get in little bits. So you might not do it perfectly every single time. I know I certainly wouldn't in clinical practice because things do get in the way, but even just opening it up so that there is, as I said, just making sure they're aware that there is a decision, that there are these different options, and if they need more time to think about it, then allowing them that more time to think about it. But just little steps first to start the process, and then it'll become easier as you go through to get that implementation in. And things like the decision aids that we've been researching here are really, really useful ways to help do that. As you mentioned, in so the musculoskeletal space, there aren't that many of them, but having the ones available that are there can be really helpful, both for the clinician to just help them be on top of the evidence base, and then obviously just to be able to provide them to the patients as well.
Yeah, I agree. It's, as a younger clinician myself, super helpful to see these decision aids to guide my own process of how to have these discussions, what I should promote that evidence suggests, what questions the patient should ask me probably, and or their surgeon, and a physical copy of something to look at and reference. And yeah, it's great for the patient and the providers. So I'm thankful for all of y'all Australians who keep crushing these decision aids. I don't know of anyone who's done it in the States yet. Maybe I'm missing something, but y'all are doing something right over there. Do y'all know of anyone doing any of these decision aids in the US? Just Australia?
There's a couple of people, and there's quite a few people in Canada as well who've been developing decision aids.
Got it. Awesome.
There's actually, it might be worth mentioning, there is a decision aid library. I'm not sure if we can link that in the show notes, but
totally.
That's where a lot of them are kind of stored with links, or that's where links to all of those decision aids are kind of managed. Yeah.
Yes, that would be extremely helpful. I wish I would have found that sooner. Yeah, we'll link that. We'll link y'all's decision aid and the paper you just published, and then more information on the two of you. Any more thoughts before we wrap it up? Perfect. All right, we'll call it there. Julie, Hazel, thank y'all so much.
Thanks so much.
Thank you very much, Chris. Thank you.